Good afternoon, everyone. My name is Deborah DeBruin, and I direct the Center for Bioethics here at the University of Minnesota. I want to welcome you all to today's Ethics Grand Rounds. Our format today is a little bit different from our typical Grand Rounds for those of you who have joined us in the past. This is the first of a two-part series representing perspectives both for and against legislation that would permit what some call medical aid in dying and others call physician-assisted suicide. We at the Center for Bioethics are hosting this series to inform public discussion about such a bill currently under consideration at the Minnesota legislature. We decided to host these two events rather than a one-time debate to allow for more opportunity to explore the complexity of issues and the diversity of perspectives. The second event is planned for Friday, February 11th from 3 to 4:30, and we hope that you'll be able to join us for that discussion as well. The plan for today is to hear from all of our speakers and then to engage in what I'm sure will be a rich and interesting discussion. While we will not address questions until after all the speakers have presented, you should feel free to submit your questions at any time using the Q&A feature at the bottom of your screen. If you have technical issues, please let us know in the chat, and center staff will address those issues as quickly as possible. Before I introduce today's speakers, I'd like to thank our events coordinator, Kayleen Jacobson, for all of her hard work to help organize this series. I'd also like to thank our co-sponsors, the medical school, the law school, the School of Public Health, and the School of Nursing. We very much value their partnership. Without further ado, then, let me introduce today's speakers. We are really fortunate to have such an amazing group with us today. In the interest of time, I'm going to keep these introductions very brief. We will put links to their full bios in the chat for your information. So we'll begin with Ms. Danna Nelson, who is a patient advocate for the organization Compassion and Choices Minnesota. She will share her perspective on these issues as a patient with a terminal illness. Next up will be Dr. David Grube, who is Compassion and Choices' recently retired medical director. He will discuss the issues from the perspective of a clinician. Next, Minnesota State Representative Mike Freiberg is chief author of the bill before the Minnesota legislature. And finally, Professor Thaddeus Pope from the Mitchell-Hamlin School of Law will analyze the issues from his perspective as an expert of bioethics and health law. I would like to offer all of our speakers my warm welcome and my gratitude for their time and for sharing their experience and expertise. Ms. Nelson, at this time, I'll turn it over to you.
Hi, everyone. Thanks for joining us today. I'm Danna Nelson, and I'm 25 years old, and I'm an advocate and storyteller with Compassion and Choices. But I wouldn't say it was always comfortable or easy talking about and thinking about medical aid in dying for me. In 2018, after having lived and studied in Finland for 3 years, I was diagnosed with rhabdomyosarcoma, a rare cancer of the muscles and soft tissue. Mine appeared right here in my face and my maxillary sinus. Navigating the health system in a foreign country to ultimately receive a serious diagnosis was really difficult, so it took a long time to get there. But once we learned it was serious, I quickly began treatment, which would involve over a year of chemo and radiation. I was lucky to have my mom join me in Helsinki for treatment so that I wasn't alone. In May of 2020, in the heat of COVID's first lockdown, my scans revealed a 3-centimeter tumor in my parotid gland, which is the biggest salivary gland in my face, and I was going to have it removed. The surgery, called a parotidectomy, would be 6 hours long, and I would come out of it with a heavily paralyzed right side of my face. The paralysis was mostly temporary, although I still notice a bit of it now. During the follow-up appointment with my surgeon, he said he felt that confident that the cancer was going to leave me alone now, and that I could go look for a job, maybe get back out into the dating world, and just live my life as a 24-year-old should. That's what I tried to do, but it wasn't easy. After living under the safety blanket of the hospital and constant care for so long, it's always really jarring, while also a huge privilege to put myself out there again. After a cancer diagnosis, nothing ever feels permanent, as some lucky healthy people might believe. I lived a beautiful summer as free of cancer as it had been since before my diagnosis. Things quickly changed as I started experiencing shortness of breath. And as it was during the pandemic, I wasn't sure whether it was COVID or cancer, but some scans quickly revealed that there were large tumors in the lining of my lung and a lot of fluid gathered there. I was sent right away to the emergency room to have my lung drained for what would be the first time of so many thoracenteses or lung draining procedures. My prognosis was grim. One doctor told me I'd be lucky if I made it to Christmas, and it was already September. So my parents and I made the hard decision to move me home from Finland to Minnesota after being there for over 5 years. Shortly after moving home to Minnesota, a high school classmate connected me to Compassion and Choices, and I started to think more seriously about medical aid in dying and what it meant to me both as an advocate and as a terminally ill person. I've always felt that I don't think I would personally utilize medical aid in dying in the end, but that I desperately want to have it as a choice and as a tool to have control in the end of my life if or when the pain becomes unbearable. I also know that there are a lot of other terminally ill Minnesotans who just 100% deserve to have medical aid in dying as an option. January 2nd of this year, 2022, I was admitted to the hospital for 3 weeks, where I experienced incontinence, severe hallucination, and the inability to breathe comfortably, even with an oxygen tank. Now more than ever, I fear what the end of my life will look like. I am scared, and I want and deserve the control that having medical aid in dying as an option in Minnesota would give me. Thank you.
Well, that was a very powerful story, Ms. Nelson, and I thank you very much for sharing it. I know that it's difficult to share that, but I really appreciate it, and I wish you all the best.
Thank you, Dr. Grube.
So I will be speaking to the topic today from the perspective of a physician, and I'll just give you a little bit of background about myself before we start. Although I do have a deep connection to Minnesota, as I have 2 daughters who live there and 3 grandchildren. So I come to Minnesota often, and I love your state. I'm in Oregon. I practiced family medicine here for 35 years in a small town called Philomath. Had a full practice in family medicine, taking care of delivering babies and taking care of people at the end of their life. We call that cradle to grave care. I've been involved in the world of hospice for a long time, because in family medicine, certainly there is on a regular basis the need to deal with people with terminal symptoms. And so I've been involved in our local hospice, which was originally called Benton Hospice Service and then moved to a new name of Lumina Hospice since 1980. And I've been on the board of directors a couple of times. I've chaired the ethics committee and been on the ethics committee for many years. And I've been on the Oregon Medical Board, which is the disciplinary and licensing board of our state. And so I certainly know the administrative law quite well. And as was mentioned, I was the national medical director for Compassion and Choices from 2014 until just a few weeks ago. I would like to say that while my slides do have Compassion and Choices template, I am no longer associated with Compassion and Choices, as it was time for me to pass the torch. But I have their permission to give this presentation. I want to define for us simplistically and at the very beginning, what is medical aid and dying? So it has these components. The person who requests a prescription to end their intolerable suffering must be terminally ill. That means that they must have less than 6 months to live. They have to have capacity. That means they have to understand informed consent. And Dr. Pope will speak to this, of course, in a minute. They ask their physician for a prescription, which they can choose to take at a time of their own volition to end their intolerable terminal suffering. I say that over and over again because the topic today is not about dying, and it's not about physicians, and it's not about anything else, but addressing the issue of intolerable terminal suffering. Now, in the United States now, there are 10 states that have the End of Life Option Act that you're going to be hearing about today, including the district and also the District of Columbia. And quite a number of other states, such as Minnesota, are looking at legislation to empower patients to have this option, end of life option. These are the states that are in blue. Oregon was the first state, the state where I practice, and it enacted it over 25 years ago this year. In Oregon, it was, rather than called End of Life Option Act, it was called Death with Dignity. A first patient asked me for this option in 1999, although of course I've had conversations prior to that time. And so I honored their request. And from 1999 until 2012, I had approximately 30 patients where I acted either as the attending physician or the consulting physician. I want to bring this to your attention because as many people address this issue, both this time and next event that the Center for Bioethics will be having in a couple of weeks, I have the experience of this, and the other individuals are thinking about the theory of it. I can tell you the reality. And there are a number of end-of-life options. Of course, the default in American medicine is to do everything for everyone all the time, which is pursuing life-sustaining treatments. That's most people's choice. But these are other alternatives, including hospice and palliative care, which are so valuable and so important. I'm going to be repeatedly speaking to them today. But our topic today is the bottom one, medical aid in dying. And before we go much further, I think it's so important that we talk about language. Now, I imagine on the next episode of these two-part series, a number of individuals are going to be talking about assisted suicide or physician-assisted suicide. This is not about the physician, and this is not suicide. And I'll try to explain that for you in another way. But there are a number of different words that are used, and I think it's really important for us to use appropriate language and use language that is not mean, that is not causing shame or harm or anxiety. Excuse me. Because indeed, there's a big difference, and even the American Suicidology has come out with a statement: medical aid in dying is not suicide. For those who use suicide, they most often do not have a terminal diagnosis. They have some type of mental health problem, whether it's addiction or post-traumatic stress disorder or major depression. They are not about to die, but they have chosen that they do not want to live. Individuals, on the other hand, who opt for medical aid in dying would like to continue to live, but will not be able to. And they have capacity. They understand what they are doing. Yes, they are grieving. They are sad, but they don't meet the criteria for major depressive disorder. Individuals who use aid in dying plan this out. It's planned with their family. It's not impulsive or violent, as so often happens in cases of suicide. And the death is gentle as opposed to a violent death, as I mentioned. And the grief reaction is quite normal. We recognize this in several studies. in individuals who choose aid in dying. And the grief reaction is abnormal, of course, in suicide. The family, the loved ones, the caregivers, the doctors and nurses all wonder what we could have done to recognize what was happening in this individual who was not dying but chose to commit suicide. And as Dr. Pope will probably mention to you, all the states, all 10 states and the District of Columbia, and in your bill that is coming to the legislature, it is legally stated that aid in dying is not suicide. So have to be a Minnesota resident, have to be an adult, terminally ill, have mental capacity, and it must be able to self-ingest because the medicine is taken orally. And we could talk about it at length in the question and answer period if you would like. Now, this is not necessarily a simple thing. In most states, not all states, but in almost all states, there are components. The individual must ask twice to a person called the attending physician, and this is usually separated by a couple weeks, for this option, and to another doctor, so 2 doctors. And then they also must fill out a written request from 2 different witnesses, one of whom cannot be related. So these are quite a number of steps that we have to do in Oregon and most other states. There are a couple little different caveats in a couple states like New Mexico and Hawaii, but for the most part, that is the law in most of the states. It is a team that does this. It is not an individual. So there's the prescribing doctor who's the one that writes the prescription. There's a consulting doctor who confirms the diagnosis and capacity, etc. But there's also mental health providers. If there's any issues at all of loss of capacity or an issue for example, of depression, etc., that can be employed. And also other individuals do assessments and evaluations, including the pharmacist, the hospice nurse, social workers, and the chaplain. This is very, very important to know these because some of the questions that you might have are, how does a doctor or a couple doctors know that the person isn't being coerced or that they have capacity? Well, it's because this is 19 times out of 20 a team process. As I mentioned, the attending doctor is the doctor who will write the prescription, and these are her or his responsibilities to do the assessment, to refer to the consulting doctor, and to refer for hospice if that's appropriate, and it is almost always appropriate, and that the individual should notify the next of kin, and that they shouldn't take the medication alone. The consulting doctor, as I mentioned, the second doctor, confirms the prognosis and diagnosis, and also counsels the patient, and would also could refer for mental health evaluation if that's necessary, which is quite uncommonly is necessary. It's very rare that these individuals need a mental health referral. But I get back to the fact that this is not just 2 doctors. It's the whole hospice team. It's the hospice nurse. It's the compounding pharmacist, because these medications must be compounded. It's the navigator, who is usually the social worker, who's the person who has gone through and held the dying person's hand as they go through the process. And of course, the spiritual support of a chaplain. In our ethics committee at our hospital here in Oregon, where I practiced, we went through decided to make a little flow chart to see what it would look like for someone to go through the process. So in the brown sort of ellipse up in the left upper corner, that's when the person made the first request, and the brown ellipse in the left bottom corner is when they ingested the medication. And these are the steps that I just outlined for you if everything goes as planned. So it's not a simple just to get a pill kind of a situation. Very thoughtful, very thought out, protective for individuals such as those with disabilities, etc. Very, very important to understand that this is something that is a well thought out situation. No doctor or nurse has to participate. And if under the act in Oregon, and I am sure in the act in Minnesota, individuals use the process that we're outlining, there is not a risk for a suit, and no one has ever been lost a lawsuit, or had any disciplinary action from any nursing or medical board for either deciding to participate or declining to participate. The medical aid in dying does not impact social contracts such as health insurance. And as I mentioned again, is not under the law mercy killing, euthanasia, homicide, or suicide. I want to show this graph quite briefly because it outlines a couple important things. First of all, these are the data from Oregon up until last year. The new data will come out next week, but it will be similar. The point is two things. There are very few people many people want to talk about this, very few people request it. So in Oregon, it's 0.4% of our deaths. We have 36,000 deaths in Oregon every year, and the most that there have been with medical aid in dying is around 200. But more importantly, fully 1/3 of individuals who talk about and end up going through the whole process, as Ms. Nelson mentioned, then don't take the medication. They just want to be empowered, as she mentioned, to have the option, which is palliative. And we are talking about intolerable terminal suffering. Anything that we do that is palliative, that is kind, is valuable medically. So, as I mentioned, since 1997, there have been almost 3,000 prescriptions. A third of the people took the medicine. The main diagnosis, of course, is cancer, but the neurodegenerative diseases such as Parkinson's and ALS are on the increase. Almost everyone, I write greater than 90%, it's closer to 95%, are enrolled in hospice. There's never been any evidence of abuse reported. And this is really, really important because one of the arguments that is raised against aid in dying is that people who have disabilities or minorities or the poor or women will be coerced, or there were not enough protections. And this has never been shown to be the case. In fact, the disability rights executive director in Oregon has repeatedly stated there's never been evidence of the disabled in Oregon having been taken advantage of by this law. So keep that in mind as you come to your understanding about what aid in dying is. Why do people choose aid in dying? Interestingly, it's not so much trouble with actual pain, because we handle that pretty well these days, but it's a loss of autonomy. They're feeling that they are out of control. Their loss of dignity when they're no longer able to control their bodily functions, their fears, and anhedonia, no pleasure left in life. There's nothing for them. And we, as the hospice team and palliative care team, have done everything we can, and yet they're having intolerable terminal suffering, defined by them. We cannot define their suffering. Remember that too. Suffering is not defined by the healthcare team. Excuse me. Health insurance covers this in state health insurances and private health insurances, but not federal health insurances won't cover the medications. This is very, very important because there's been in Oregon a very positive impact on hospice and palliative care because of our Death with Dignity Act. And now we lead the nation in the utilization and appropriate utilization and use of hospice for all states. And we're very proud of that. And I think part of it, and some studies are suggesting, that it's because we have full end-of-life conversations with our dying patients. I mentioned this at home, but also before, but also people don't want to die in the hospital. They want to be in their home. This is very, very important because one of the arguments that you might hear in people who oppose aid in dying is that it erodes the doctor-patient relationship. Well, I personally, and through conversations with peers, can tell you the opposite is true. Because when a dying patient who is suffering can talk to their doctor about all of their options and choose the one that is correct for them, that enhances the doctor-patient relationship because they know they can trust their doctor to give them all the information and all the choices for them to make on their own. Cicely Saunders is essentially the mother of hospice, a wonderful person from England. And she said, total pain is the suffering that encompasses all of a person's physical, psychological, social, spiritual, and practical struggles. This is so true. So here we are, there an ethical dilemma: to extend life or relieve intolerable terminal suffering. It's not just about suffering, because suffering can have some benefits sometimes. But when a person is about to die and has a few weeks left and are having suffering, that is what we should be talking about. And the 4 pillars of medical ethics, as I'm sure that you all know, are autonomy, which certainly aid in dying aligns with; non-maleficence, primum non nocere, which means, first of all, don't do any harm. Again, the healthcare team and the physician is not the one who defines harm. Historically, that's been the case. We thought we would know what's good and what's bad, what's harmful and not. No, this is also defined by the patient. And I can tell you many patients who thought that the chemotherapy, or et cetera, that was sort of foisted on them, they felt ultimately was harmful to them. Beneficence: is this a kind and good thing to do? And this again would be defined by the patient. So if we listen to the patient, the pillars of medical ethics support aid in dying, in my opinion. I've often asked the question, what about the Hippocratic Oath? Well, interestingly, the Hippocratic Oath is not taken by any medical students and has not been for more than 20 years, the last medical school that employed it. And in 1973, the Supreme Court of the United States declared that the Hippocratic Oath is invalid in consideration for ethics because of the increase in technology and therapy, which we have in our world today. It gets down then ultimately to professional integrity versus personal beliefs. When I was on the Oregon Medical Board, I more clearly understood what it means to be a professional. It means to put the patient first, not to put what our beliefs are, our ideas are, but what the patient wants, and to abide by their wishes. If this is not something that we can do, then we should refer the individual. But our personal beliefs really are our personal thing, and the tension in ethics is when they surpass professional integrity. The American Medical Association is opposed to medical aid in dying, and yet they believe that medical aid in dying is an ethical practice. It's kind of a schizophrenic opinion. I had an opportunity to debate Dr. Macy, who will be speaking to you in your next program, and the ultimate decision at that AMA meeting 3 years ago in Chicago was that medical aid in dying is ethical, but medical aid in dying is unethical, but doctors who practice medical aid in dying are ethical, which is confusing to me. So this is a quote as I close from Atul Gawande in his wonderful book, Being Mortal. The scientific advances have turned the process of aging and dying into a medical experience. This is true. I heard a hospice nurse once say that you can't die in the United States anymore without an ICD-10 code. We need to be thinking about dying as a natural process, and our role in that is to comfort the patients who are dying and respect their wishes. So I'll say it again, the issue is not about dying. The issue is about addressing intolerable terminal suffering. In my last slide, in Oregon, since our End of Life Option Act was passed in 1994 and enacted in 1997, the same number of people have died. but fewer people have had intolerable terminal suffering. Thank you.
So I believe I'm up next. Thank you, Ms. Nelson and Dr. Grube, for your testimony. It's always just, I'm always kind of in awe of the bravery of people such as Ms. Nelson, who are able to share such a personal and difficult story. It's really affected me just deeply, and increased my resolve when it comes to advocating for this bill, which is a really important bill. So, I was just asked to kind of talk about the specifics of this bill, as well as how it differs from some of the bills that have been introduced in other states. So I will just do that. I don't have any slides. But I'll be talking about how the Minnesota End of Life Options Act differs from the Oregon Death with Dignity law. And that's kind of the first place I'd like to start, is actually the title of the bill itself. Now, as I understand it, in Oregon, the Death with Dignity law was passed by a ballot initiative, and there was no opportunity to amend the title of the bill as a legislative process would have allowed for. And one thing I've heard from people on both sides of this issue is that there are lots of ways a person can die that have dignity, and I completely agree with that, and this isn't the only one. So I personally don't use the title Death with Dignity because I think it's under-inclusive. I think there are other ways people can die that have an equal amount of dignity. So this is just called the Minnesota End of Life Options Act, which is a more technical description of what it allows for. So just with that mentioned, I just want to emphasize the primary features of the law are the same as those in the 10 states plus the DC that have authorized the practice. And Dr. Grube spoke about those a bit, but just to be clear what's in the Minnesota bill specifically, it spells out very explicitly what criteria are in place for who is eligible to use it. So the person has to be an adult, meaning they're at least 18 years of age. They have to be a resident of Minnesota, and this is to avoid any legal implications for patients and families if the medications are ingested in a state where medical aid in dying is not authorized. They have to be terminally ill with a 6-month or less prognosis, and this conforms with hospice eligibility. They have to be capable of making medical decisions, as explained by Dr. Grube. They have to be able to self-administer the medication, and Professor Pope can discuss the implications for the legal language around self-administration. There's a specific process in place under the Minnesota bill, and Dr. Grube spoke about it. The patient has to make a written request as well as 2 verbal requests. 2 doctors have to receive and document the verbal request. They have to confirm the patient's eligibility, and they have to confirm the patient's mental capacity, including their volitional capacity. If mental capacity is in question, either physician may refer the patient for medical health evaluation, which is a final evaluation. The patient has to be fully informed of all options. They have to meet the standard of informed consent. And they have to be offered a referral to hospice if they're not already enrolled in hospice at the time of the request. And the patient must be instructed in the proper use of the medication and disposal of any unused medication. We heard that many people who are prescribed the medication don't actually use it, so that's an important component. They are encouraged but not required to notify next of kin, and they are encouraged to have someone present at the time of ingestion. So now there's more than 60 years of combined experience, including 25 years just in Oregon alone. And it's become clear that several components of the law that were designed to be safeguards have really served somewhat as barriers. So there are some distinctions between the bill as introduced in Minnesota and the law in other states. So one distinction relates to authorized prescribers. So the bill I've introduced with Senator Eaton includes nurse practitioners as eligible providers. So most states, with the exception of New Mexico, limit prescribing authority to physicians. But states that have a large amount of rural areas, such as Minnesota, have granted independent practice authority, which includes prescribing authority to advanced practice nurses to compensate for provider shortages in greater Minnesota. So that's why I've included advanced practice registered nurses as either consulting or prescribing providers. The Minnesota legislature has already determined that they are qualified to meet and provide care that meets the standard practice of medicine. So there's a second distinction relates to witness signatures. So there is a requirement for a signature of a witness in other states, but it's not in the bill. If you look at other medical procedures, there's no requirement for a witness signature for surgery. So it seems odd to have it here, but I'm open to discussing it further if people feel strongly about it. Some of the language in other states has a waiting period. The bill I've introduced does not require a documented waiting period. So in recent years, several states with long waiting periods, usually 15 days between requests, are either reducing the waiting period to 48 hours or giving physicians the authority to waive the waiting period altogether if the patient is unlikely to survive the waiting period. Kaiser Permanente data showed that 20% of patients who requested medical aid in dying died during the waiting period. The other problem that arises is when the clock begins. So if the patient's first request is made to a non-participating provider, that provider has to document the request for the clock to begin. My bill does not require a non-participating provider to document, and patients are not disadvantaged by a time restriction. Finally, the requirement to see two separate doctors provides basically a built-in waiting period. There continues to be discussion related to health professionals' right to opt out of providing medical aid in dying if they morally object. Sections 2 and 3 of the bill address prohibitions and duties. I'm open to discussing the exact language in the bill so long as it meets a few fundamental principles. So first, no health professional should be required to participate if it goes against their personal beliefs. Healthcare facilities may prohibit participation by their employees on their premises. Physicians should not be required to recommend medical aid in dying, but if the patient requests it, they or their healthcare institution must provide accurate information about the option. Facilities may not gag their employees from discussing medical aid in dying, particularly when a patient requests information. And facilities must cooperate with transferring medical records if a patient chooses to transfer out of a non-participating facility. So that's just a brief overview of what's in the bill and how it is different from laws that have been passed in other states. Looking forward to the question and answer period. Happy to talk about it further, but that was pretty much what I wanted to say. So I will hand it off to Professor Pope.
All right, thank you. I'm going to share my screen. Okay, so my role here at the end is to respond to objections. And what I'm going to respond to are objections that were actually made already to the Minnesota legislature. So here in Minnesota, we have had 8 made bills since 2015. 2 of those bills have received public hearings. 1 in the Senate, 1 in the House. So in 2016, this Senate bill, sponsored by Senator Eden, had a hearing before the Senate Committee on Health, Human Services, and Housing. And then in 2019, this bill by Representative Freiberg, who just spoke, received a hearing before the House Health and Human Services Policy Committee. So what I did was I reviewed those objections from those 2 hearings, both the oral and the written testimony. I'm going to summarize the more prevalent objections and then respond to them. Okay, so here's the roadmap. I picked 5 objections just to keep this manageable. And first, I'm going to talk about that there's a concern that MAID will be driven by bias and prejudice. There's a concern that MAID will be driven by money. A concern that the procedures that Dr. Grube described will fail to assure that the patient has decision-making capacity, a concern that the procedures will fail to assure that the patient has a terminal illness. And then finally, there's a concern about abuse of the vulnerable. Okay, so first objection, bias and prejudice. So this is Anne-Marie Hansen testifying before the House in 2019. She's the president and founder of Gianna Homes. Gianna Homes has several facilities, they're memory care facilities where they take care of people with later stage dementia. And this is Kathy Ware testifying also in 2019, testifying on behalf of and with her mentally disabled son. What they both charged in that hearing was that they're concerned that patients with dementia and patients with mental disabilities will involuntarily get made because of bias, bigotry, and prejudice. And this is the response. There is really a 0% chance of that, sort of based on a misunderstanding of what the bill does. Those patient populations are ineligible for MAID for at least 3 reasons. First, people electing MAID have to have decision-making capacity. Second, the person electing MAID has to make the request herself. It's never the case where one person can elect MAID for a different person. And third, the person electing MAID has to be terminally ill with a 6-month or less prognosis. So let me just take Kathy Ware's son as an example. Nobody can say that he should have MAID because his life is not worth living, right? Only he would be entitled to make that judgment about his own life. Plus, he can't make that judgment in any case because he lacks decision-making capacity. And he's not terminally ill. So in any case, if you look to the other 11 states, there's 0 evidence that anybody with dementia or with a mental disability ever got medical aid in dying. And that's notable because we have more than 80 years of combined experience with medical aid in dying in the United States. When you look at the duration that MAID has been a legal end-of-life option in the 11 jurisdictions where it's available. Now, absolutely, we have a problem with bias and prejudice and bigotry in US society, but there's just no evidence that it's connected to MAID. Second concern is that MAID is or would be driven by money. So this is Dr. Callister. He'll be speaking on February 11th, but this is him testifying in 2019. And he says there's going to be movement to the cheapest treatment, which he says is MAID. Minnesota Citizens Concerned for Life submitted written testimony, and they say that there's going to be a financial incentive to steer patients to MAID. And here's my response, right? First, there's no evidence of any pushing or driving for financial reasons. There's just no connection. Plus, this whole argument is based on a false premise because MAID doesn't actually even save money. MAID patients are already on hospice. So every state that has MAID puts out an annual report from its state Department of Health, putting out demographics on who used MAID and why. And so, of course, Oregon, since it has the longest experience, has the most data. So let me just give you the Oregon data. 95% of people who got MAID were on hospice. That's significant. Why? Because the Medicare hospice benefit requires that when you elect hospice, you have to give up curative directed treatment directed toward the terminal illness. So for example, most people that have ever received MAID in the US and in any other country, their terminal illness was cancer, right? When you go on hospice, you have to give up all that oncology treatment, whether chemo or radiation or surgery or whatever it is, right? So they're already not receiving that expensive treatment. There's just no evidence of any hurting or steering because of financial reasons. The next objection is that the procedures that Dr. Grube described fail to assure that the patient has decision-making capacity. So MAID is only available to patients with decision-making capacity. And as he described, that's assessed by both the attending physician and also by a consulting physician. So there are two assessments. Sometimes there are three, because if either the attending or the consulting physician is uncertain about the patient's capacity, then they have to refer to a mental health specialist. Now, MCCL, Minnesota Citizens Concerned for Life, and Minnesotans Against Assisted Suicide put in testimony concerned that the referral rate to that mental health specialist is too low. So if you look at the data, this is just the Oregon data, between 1998 and 2020, 19 patients died from medical aid in dying. Only 69 were referred for a psychiatric evaluation. So that's a 3.6% referral rate. So here's my response, right? Yes, 3.6%, that's a low rate, absolutely. But it's not too low, right? There's no evidence that it's not a correct or appropriate rate of referral. We are able to pick out which patients have capacity and which patients lack capacity. The process that we have, two physicians confirm capacity, they refer to the third clinician, the mental health specialist, only if either of them is unsure. That works. Again, we have a proven patient safety track record. There's no evidence in decades of experience with MAID in other states that any patient with impaired judgment got MAID. Again, 78 years of combined experience when you look at these states. And one thing I did here is I did take Hawaii out of that calculation. And I'll just mention Hawaii is a little bit different. Hawaii does always require 3 assessments by 3 clinicians. So in Hawaii, the attending provider shall refer, that's the language, shall refer the patient for counseling, right? So it's not contingent on doubts or concerns about the patient's capacity, it's automatic. Every patient all the time always gets that third screening. But, and here's the point, there's no evidence that adds anything, that making the third assessment automatic adds anything in terms of safety. And why is that? Well, physicians, Minnesota physicians, are qualified and experienced to assess patient capacity. First of all, the law specifically and for decades has given them that role, including in other life and death, life-sustaining treatment situations. In fact, it gives that role to APRNs as well. And on top of that, not only are they specifically legally delegated that responsibility, they exercise it every single day. So if you have a patient in front of you, right, there's basically 3 options for that attending and consulting physician. Either the patient has capacity, they lack capacity, or you're unsure, right? And basically they are able to put almost all patients in either into that first box or the second box, and there's not really a great need to use that third box. Yes, it's there, just in case we're unsure, we want to make sure, but it's often not needed. Next objection, that the procedures fail to assure that the patient has a terminal illness, right? MAID is only available to patients with a terminal illness, and that is an incurable and irreversible disease that will produce death within 6 months, right? So the patient, to be eligible for MAID, needs to have a 6-month or less prognosis. So MCCL charges that prognostication of 6 months is inexact and often mistaken. And Dr. Callister, testifying in 2019, says that our ability to prognosticate is sorely lacking, and many patients outlive their diagnosis. So here's my response. First, in fact, on this one, I have 3 responses. First, this idea of the concept of terminal illness and a 6-month prognosis is deeply vetted and tested, right? It was first really introduced in 1983 as the eligibility criteria for hospice benefit under Medicare, right? 1983, right? That's 40 years ago next year. And 1 million people a year, more than 1 million people a year, qualify for hospice based on that 6-month prognosis. We use it a lot. And as I said earlier, that hospice election is consequential because it means that they are waiving coverage for curative directed treatment at their terminal illness. 95% of MAID patients are already on hospice. The second problem with this argument is that, in fact, the prognosis actually is accurate when you look at what we're prognosticating. So if the Oregon data will, as do the other states, tells us what underlying illness the patients who got MAID had. And 85% of the patients who have received MAID in Oregon and in the other states have had either cancer or ALS. And the thing about cancer and ALS is that we actually could prognosticate cancer in ALS pretty well. Now, perhaps with heart disease, it may be more difficult. And in fact, heart disease is the leading cause of death in the United States, but it's nowhere near the leading cause of MAID. And that may be because of the additional difficulty prognosticating there. Also, the data, the publicly reported data tells us that only 4% of the patients outlived their 6-month prognosis. But here's the most important argument that shows why this concern is misplaced, is because any imprecision, if there is imprecision in the prognostication for terminal illness, it's completely irrelevant, because terminal illness is only an eligibility requirement. If you're terminally ill, yes, that may qualify you to get a prescription. A prescription, right? You may not even actually have the drug. But the one thing you're definitely not doing yet is you're not ingesting the drug. That's going to happen later, if at all, right? Most patients mix the drug with something like apple juice. They may drink it. Some patients may press a plunger on a feeding tube. Some patients may press a plunger on a rectal tube. But that's going to happen later, if at all. This is the Oregon data. The green line over time, over the last 25 years, is the prescriptions written. The purple line are the deaths from ingesting those medications. And you see that the green line is always above the purple line. Between 1998 and 2020, 2,900 prescriptions were written. There were only 1,900 deaths, right? More than a third of people who get the prescription never ingest it. They have it just in case, but they never actually needed it. And nobody ingests it just because they get a 6-month prognosis, right? They ingest it when the burdens of their terminal illness become too much for them. And sometimes they don't become too much for them. So this argument just completely misses the target. And then finally, there's a concern that the vulnerable will be abused. So MCCL is concerned that the vulnerable and the disadvantaged will be pressured into using MAID. But these worries, which have been around since the beginning, have just never manifested. These are educated, well-off people. 95% graduated from high school, 73% went to college or grad school, 99% are insured, 96% are white. This is not your vulnerable and disadvantaged population that's using MAID. So let me just wrap up, right? When we make policy decisions in Minnesota, for example, about whether to enact the End of Life Option Act, we need to base policy decisions on reliable evidence, right? And we have reliable evidence. We have the experience in other states. We have expert review panels. We have peer-reviewed literature. And I just want to ask you, when on February 11th, if you guys tune in for the other session, ask yourself, what kind of evidence are those speakers presenting? Because what they usually present, what they did present in the 2016 and the 2019 hearings, is at the bottom of this pyramid of reliable evidence. It's anecdotes and opinions. It's not reliable evidence. Thank you.
Thank you all. There's been a very active conversation going on in the chat and in the Q&A during the talks, and there's a lot of fodder for discussion here, and I am going to do my very best to get us to as many questions as I can. I will just encourage people, if you have additional questions, to put them in the Q&A function. There may, I just think, given how active the conversation has been, there may very well be further issues that we can't get to, and we will try. We had a conversation at the outset before we began today, get the panelists to provide some answers to some of the questions that we don't get to today afterwards. So we'll be in touch about those things. Let me just see here. The one question in the Q&A is, how would Minnesota carry out the End of Life Option Act in state facilities like prison system, hospital systems, or long-term care facilities, for example, in places where folks may live and or be confined. Is there anything special or particular about the rules there?
I guess I would just say the standards for medical care are the same. This is a medical option that's available to people who meet very specific criteria, and I think it would be available in those settings as well, as long as they meet the criteria.
So there's nothing in the bill that prevents it from being available in those settings?
No, and I'm not aware that any of the other states have anything like that.
I mean, and the bill, Freiberg's bill, right? It does say, that it's optional, right? So if you're the director of a particular facility, and I guess I don't know how much independence the director of a specific facility has versus the secretary of DHS, but generally, each individual facility can either opt in or opt out, right? And so I guess that rule could apply, that you could be the director of some county prison, or I guess we might even have private prison systems in Minnesota, but you could decide we're not going to participate, or we are going to participate. So nobody generally needs to participate if they don't want to.
So Representative Freiberg, I know that during your talk, you talked a little bit about the point that Professor Pope just made, that is to say that individual providers can opt out and particular institutions can opt out. You mentioned that there were provisions in the bill to prevent that opting out from becoming a barrier to people receiving MAID if they chose, right? That they had to be able to go elsewhere for it, for example, right? I wonder if you could speak to that, just to clarify that for folks. Striking that balance.
Sure. I'm posting a link to the bill language itself. I always think, whoops, I think that's, okay, let me send it to everyone. I just posted a link to the bill language in the chat. So I always think the bill language itself kind of speaks the most clearly to these issues. So if you look to page 8, line 4, or line 8.4 there, subdivision 11 of section 1. It just says the heading is that there is no duty to provide medical aid in dying. So the bill language says pretty specifically, a provider may choose whether or not to practice medical aid in dying pursuant to this section. If a provider is unable or unwilling to fulfill an individual's request for medication pursuant to this section, the provider shall, upon request, transfer the individual's medical records to the new provider consistent with federal and Minnesota law. A provider shall not engage in false, misleading, or deceptive practices relating to a willingness to qualify. So it says very clearly they're not required to participate in it, in those sections, but it does, it does provide some safeguards though, to ensure that the patient is provided accurate information regarding, what options are available to them, but it does not require any provider to participate in that.
Thank you. Anyone else want to add anything to that? Next question is directed to Dr. Grube. When you were on the Board of Physicians, how many doctors were referred to the board under this act? Were there grounds for complaint? Is really the question. And what were the outcomes?
Yes, so I was on the Oregon Medical Board for 7 years. During that time, there was never a referral to the board from a family or institutions or other physicians for this. But several times each year, the Department of Health would uncover that the physician may or may not have specifically exactly complied with the act. And if those outlying conditions occurred, those cases would be referred. So I would say roughly 2 or 3 situations a year, cases a year, came from the Oregon Department of Health. They were always such things as not filling the form out correctly or completely, or rather than waiting 15 days, they waited 14 days or something. So we looked at each of them individually. None of them ever rose to the level that was consistent with inappropriate application of the. So we would send these licensees a letter of concern about appropriate use of the act, but there was never anything that rose to a level of concern in all those years that I was there.
Thank you. Anyone else have anything to add to that? So there are a number of questions about dementia. So my understanding is that people who are diagnosed with dementia do not qualify for medical aid in dying under the bill before the Minnesota legislature. There are, of course, folks who would advocate for the use of medical aid in dying in dementia, especially if the patient put in an advance directive before they substantially lost capacity. And I'm wondering if we could talk a little bit about the issues around dementia and eligibility.
I'll speak quickly about that. Essentially, it's so important at the moment of ingestion that the person has capacity to know what they're doing. Not that they thought about it 10 years ago or 5 years ago, because as each of the speakers has spoken, particularly Ms. Nelson, our thoughts change as situations change. So at the moment of ingestion, capacity is necessary. I've actually had patients, and I know of many situations where an individual began the process and because of their disease lost capacity, not necessarily dementia. Sometimes if they had brain metastases, yes. But at the moment of ingestion, they had lost capacity and therefore they were no longer eligible and aid in dying was not applied.
Professor, oh, sure. Just again to refer to the bill language, just because I know this is a question I get asked a lot. The definition of mentally capable is on line 2.24 of the bill, and it says that the person, it's required that the person has the ability to make and communicate an informed decision, and then informed decision is defined on line 2.4. This is something I've been asked by people. They want, people are very afraid of dementia. I am as well. I have people in my family who've been through it, and they want to have this option in that circumstance. I'm, not at a point where I'm comfortable expanding the eligibility of the law to incorporate those people, because I don't know a way you can have safeguards in place to ensure that they are making an informed decision. So, and I don't believe any state that has authorized this has done so. So, I have to tell the people who request that, I'm not comfortable doing that at this point. Maybe at some point there's some way to make sure there's a safeguard that could be put in place, but at this point, I don't know what that is. The bill would not allow for it.
So, right, you can't there's two reasons. First of all, to be really, really careful about it, you can qualify with dementia. It's just that can't be your terminal illness. You're going to need to have cancer or something else. You wouldn't qualify because of the dementia, but if the dementia were in the early stages and you had another terminal illness, so I just want to be clear that it doesn't disqualify you. It just isn't going to make you eligible, because you can't. There's two things you need to satisfy in Representative Freiberg's bill, as well as every other U.S. state law, which is you have to have capacity and you have to have terminal illness. And the way that dementia works, it's a long progressive illness. You can't satisfy those two things at the same time, right? By the time you're terminally ill with dementia, you're not going to have capacity. Early in the progression of dementia, when you still have capacity, you're not yet terminally ill. The Star Tribune did have some coverage a few weeks ago. The one thing you can do in Minnesota, as in many, many states, is you can write an advance directive for stopping eating and drinking, right? So you could say, when I get to a late stage of dementia, don't give me any water, right? Don't spoon feed me, don't hand feed me, don't give me food and fluid. And Compassionate Choices, Final Exit Network, Dartmouth, and others have all developed specialized dementia directives to achieve just that end. But dying through an advance directive, not even in a bill, right? Nobody's even proposing that anywhere in the United States.
Thank you. So there's, as long as we're on the bill language, I'm going to ask this question, which is, Professor Pope, this may relate to the kind of evidence that you mentioned in your talk. The questioner asks, has there ever been a policy study to determine how well the statutory safeguards work? I know that you talked about a lot of different data. Go ahead.
So there's actually a lot. Right. So people have studied this a lot in good like JAMA. Right. So people have studied, is this working? Right. Do we need a third capacity assessment? Kaiser Permanente clinicians have published on their, because it's a very big system in the state of California. They've published in JAMA, they've published in other journals. The parliamentary, just give you an example, we're not the only ones doing this, right? So Australia, each state in Australia, so Victoria, and then it went to Queensland, and it went to Tasmania, they all commissioned specialized expert review panels where they brought in people from Oregon to Australia, did these are big reports. These are like 600-page reports. They carefully vetted this evidence, and Australia and now basically every state in Australia has medical aid in dying. They based that on the US experience. So the evidence and the experience of how MAID is working from a patient safety perspective has been rigorously reviewed again and again and again by lots of independent experts.
Thank you. So related to the issue, and this is not so much about kind of statutory protection so much, but some concerns about the way that the practice may play out. One of the questioners says that, one of the sort of the fulcrum here is autonomous choice by the patient who is choosing MAID. But the concern is that patients may choose out of a concern about burdening their family or because of pressure that they're receiving from their families or socially. And I'm wondering if you could respond to those concerns. I'm not sure if the statutory language quite addresses those issues.
Well, I'd be happy to talk about that. A burden to the family might be put in the category of existential suffering. And as Dame Saunders said, existential suffering has as equal value as physical suffering. For those people who are dying, these are people who are suffering and dying, and their suffering could be existential, psychological, physical, etc. The thing about medical aid in dying and the statute that Minnesota is looking at and that we have in Oregon requires that the physician evaluate the patient, which means asks questions, which means when the person says, I don't want to be a burden to my family, it means the clinician and the healthcare team, the hospice nurse, the chaplain, the social worker, the registered nurse, all ask, what does that mean? What does a burden mean? Can we address that? And so often we can address that and the situation gets taken care of. And that's the great thing about this law in Oregon and possibly in the future in Minnesota, is that having the conversation about aid in dying as an option opens the door to improved communication, improved trust, and that is palliative. And these people are about to die, and anything that we can do that is palliative is the right thing to do.
I guess I will say that the bill does have language related to coercion and undue influence also. So if you look to line 1.13, there's a definition of coercion or undue influence there. And if you just do a control F and search for the word coercion, you'll find it throughout the bill and how it's illegal to coerce anybody who does not want to undergo medical aid in dying.
Thank you. Related to those issues about coercion or perceived pressure, some folks in the questions have been asking about whether or should raise the issue about MAID with patients themselves if the patient hasn't asked or requested. Is it permissible for a healthcare provider to raise it as an option? And is there a worry there that patients may take that conversation as sort of direction or pressure from their clinical team?
Well, this is the art of medicine, right? And how we talk about anything, not just aid in dying, but all things. And when we give patients options, how we present them. So the good clinician, the palliative care clinician, the hospice clinician, would include it in their palette of the conversation, but there's ways to do that. And I might give an example. One of the great palliative care questions is, your death is very near. How do you perceive your last day? What do you want on your very last day? Do you want to be at home? You want to be in the hospital? Do you want to be with your family? Are there people you don't want around? And you listen to what the patient has, and you can include that in the conversation by saying, do you want to choose the day so that is not that's one example of a way to have the conversation. I heard a doctor in California say, in a way, if you have the options that you should outline to the patient and you don't present them, it's like going to the bank and there are 5 different ways you can refinance your house, but the banker only gives you 4 because he doesn't like the last one. You know, again, there are styles and ways, and just like the language that we use.
Thanks. Sorry, Professor Pope, and I think Ms. Nelson was also trying to unmute herself.
Yeah, sure. I would just like to say thanks to Dr. Grube for saying that, because I completely agree that you wouldn't want to say it in any way. You could say it in a way that would feel like pressure, coming from the patient's experience and having felt never at a point in my treatment pressured to do any one thing and to always feel like it's my choice. To have that autonomy has been really, really important to me. So I definitely wouldn't want to feel in the end of my life like I was being forced or pressured in one direction, but it definitely could come off that way. So I just wanted to agree with Dr. Grube that, yeah, the language surrounding it is really important and would really be important for me.
So I mean, that's probably the most important is from the patient perspective and from the clinician perspective. But just since this is the Center for Bioethics, right, one of the most central and original concepts in all of bioethics back from the early 70s is the concept of informed consent, right? And the way it works in Minnesota is that the physician has to tell the patient all the options that a reasonably prudent patient in this patient's shoes would want to know about. Not saying that they should pick it, not saying that they will pick it, but they would just like to know about that other option. And that's a really fundamental principle. And the idea that the physician is going to, as Dr. Grube said, sort of edit some of them out because they're like, well, that's not good. That danger of paternalism that they're going to only tell you the options that they think are best for you is a really big danger. And if anything, that's where we err. We err way too heavy on that side. So there's massive amounts of data that people within days of death are still getting very aggressive interventions, right? Because the cardiologists, the oncologists are not ready to talk about advanced care planning, or not ready to talk about palliative care. So the idea that we're going to give options that are going to push patients to take those options, we're erring way too far on the other side, where we are basically coercing patients into largely ineffective, burdensome treatment.
So if I could ask, because, you know, one of the, as you all know, and Professor Pope, as you discussed to some extent in your prepared remarks, one of the concerns that's often raised in these settings is about undue pressure being placed on patients with disabilities or BIPOC, Black, Indigenous, or other people of color patients. You know, because of the kinds of concerns that you certainly recognize, Professor Pope, there certainly are, you know, issues around inequities in our culture. And with all of the sort of protections that are built into the legislation, I think these concerns about pressure continue to get raised, right? And I'm wondering if there is data about whether there is a, you know, unrepresentative number of folks from those populations who make use of MAID or any of that sort of evidence.
Well, I know they're going to mention it on the 11th, but I mean, you know, the National Council on Disability did put out a pretty lengthy report. Here's what I think is a real challenge, which is what exactly do we mean by disabled when you say these populations? Because basically, if you're terminally ill with cancer under the ADA, you are disabled. So from one perspective, basically everybody who's ever used MAID has been disabled, right? But nobody, but they chose it, right? And it's obviously a special kind of disability. It's imminent catastrophic illness, very close to death. But I guess I've not seen the data where somebody was coerced, right? Where the doctor said, hey, the doctor is talking to somebody, your life isn't worth living. You should do this, right? The person judges it themselves. I can't do these things, or I have this kind of, you know, apnea or nausea or whatever it is. You know, it's the person themselves that's making the judgment, not the doctor telling them that they need to do it. I guess, I mean, there have been anecdotal reports, but again, there are a lot of people. There are like Disability Rights Oregon, right? It's an entire specialized agency that's supposed to specifically look out for this, and they affirmed again and again and again, we've not seen it, right? We've not seen the disabled being coerced into using MAID. And none of the other federally designated disability rights organizations they all say the same thing.
Anyone else want to weigh in on that?
I think typically the doctors struggle with feeling like they've failed if they lose a patient. So I don't see why, more either they don't struggle at all with that feeling, or they feel like they struggle, or they feel like they've failed if they lose a patient. So of course I've never talked to a doctor about this, but I'm just kind of assuming, based on suggestions that have been made to me. I don't feel like I've been coerced, but I do feel um, like they typically want you to live. So I think it would be probably rare that a doctor would make a suggestion for a patient to end their life if they didn't feel like it was for the best of the patient.
I will just share that a frequent co-author of mine, Timothy Quill, who actually was a really early advocate in medical aid in dying. He is concerned about this, so he doesn't want to raise MAID. He doesn't want to raise VSED with his terminally ill patients because he is concerned that if he raises it, that's going to put some pressure on them. Oh, Dr. Quill, if you think it's the right thing, then maybe I should do it. So he is afraid that his aura of being a physician he's afraid of that. So some doctors are afraid to bring it up, but I think we have to balance that against the patient's right to know their full range of options.
So there's a question that veers us off in a slightly different direction, which is really about professional obligations, clinical professional obligations, and whether there is at base, whether it goes against your professional ethical commitments to participate in the intentional causing or hastening of death. Obviously, medical aid in dying is not just about palliation, right? So, I know, Dr. Grube, you spoke to this a bit in your presentation. If you want to expand a bit more about that, or if any of the other panelists would like to speak to it. This is the Center for Bioethics, and so obviously that those questions about sort of fundamental moral obligations loom large here.
Well, thank you for that question. Sure, it's very, very important to talk about because you have to take a step back, I think, and realize that it's not about me and what I believe as the provider. It's about the dying person who is suffering. I had a woman who was bleeding to death after I thought she was going to die after delivering a baby, but she was Jehovah's Witness and wouldn't take blood. And I just knew she needed blood. She wasn't going to live if she didn't. But I couldn't give her blood because she refused. She did not die. But it's that kind of a situation. So again, as I try to mention in my brief conversation with you, it's not about the dying. It's about honoring the patient's wishes, respecting them, and comforting them. And because they're going to die no matter what. And right now, today, at this moment, they're suffering. Now, if I, as a clinician, just can't come to the place where I support aid in dying, I do believe as a professional, it's incumbent upon me to refer that patient to another doctor. And here's the important distinction about the referral. I am not referring that patient to another doctor for medical aid in dying. I am referring that patient to another doctor to discuss end-of-life options. So I think every doctor could do that. If I'm totally opposed to aid in dying and I have a dying, suffering person in front of me who wants a medical aid in dying, I think there's no problem ethically or whatever to refer to another doctor to talk about it. It's not referring for aid in dying. It's referring to talk about that. It's no different than an appendectomy. I don't refer to a surgeon for appendicitis. I refer to the surgeon for acute abdominal surgical pain. It may not be appendicitis. It could be ectopic pregnancy. So really important, I think, to make those distinctions.
I'll just add, I mean, I don't know if this is where you were going with the thrust of the question, Deb, but right, but is it inconsistent with the idea or the mission of medicine or what it means to be a physician? You know, there've been a lot of polls, Medscape polls, right? A majority of physicians support medical aid in dying. And even the MMA, the Minnesota Medical Association, used to be opposed. They dropped that, right? As did many state medical associations. So the idea, it's definitely still, I think, in flux, right? What is this inconsistent with being a physician? Are you always a healer? But many professional societies have switched over the last 10 years.
Can you speak to the slippery slope argument about legalizing medical aid in dying is a slippery slope down to euthanasia?
Yeah, I would like to speak to that on a couple ways. One way is that it doesn't exist. This is the College of Physicians argument that there is a slippery slope, and if we do this, then the next thing's going to come along. 25 years later, Oregon has had no change in their law of any significance. There is no slippery slope. It doesn't exist in any time frame that we can measure. Second of all, we need to address what is the slippery slope, and the slippery slope is just what Dr. Pope mentioned. That is doing everything for everybody all the time, even when it's ineffective and not helpful, just because. So our slippery slope is the ICU now, where we're having dying patients with there's no likelihood of their survival, and we have them on dialysis and a cardiac machines and ventilation, etc. So there's no evidence for a slippery slope. And it's theoretical, and I think we need to talk about what is and not what if.
You know, I would just, you know, there's all different kinds of slippery slopes. The one kind of slippery slope that would definitely never happen, because there's no evidence of this at all, is that doctors would just start using IVs, right? All that happens in Oregon is Dr. Grube writes a prescription, the patient gets that from the pharmacy, the patient takes it on their own, right? No physician has ever, other than Dr. Kevorkian, of course, famously on 60 Minutes, but no physician under MAID has ever administered the medication. So they aren't going to just do that, right? The only way that would happen in Minnesota, right, to Representative Freiberg to introduce a new bill, right? And it's hard, as he can tell you. What do you have, 40 bills, right? Most of them aren't going to go anywhere, right? That's the legislative process. So it's hard enough to pass a MAID bill. The only way we would move from MAID to euthanasia is to go back to the legislature, and the public would weigh in if they wanted that or not. Probably they don't, but I'm just saying it's hard to go through the legislative process.
I will agree. It's hard to go through the legislative process. I do think my record in terms of bill passages may be a little bit higher than
I didn't mean to.
just kidding. It's fine. Yeah, no, I just think, yeah, there's no evidence of a slippery slope, and the others have said it better than I can.
So we're just about to run out of time. I'm going to ask one question that has been posed to us even prior to this event, and I will ask the corresponding question on the 11th, I promise you. So some folks today have asked if you could say what they should do if they would like to voice their support for the bill. On the 11th, I'll ask folks what to do to oppose the bill, but if you could speak today to the question about what people should do to.
Yeah, I can start since I'm used to this process. You know, contacting your legislator is always the first step, and telling them your support. And you know, legislators are people. So not everybody always thinks that, but you know, they do, I would say, tend to be moved more by stories. I know, you know, in a place like the Center for Bioethics, data is extremely important, and it is extremely important. But hearing from somebody like Ms. Nelson is just so much more powerful, I think, to legislators. You know, so to the extent, you yourself are going through this or want this option, or know somebody a loved one who wants this option, I think letting legislators know about that is so important. You know, if the bill does get a hearing, which is still somewhat up in the air. There's a public testimony process, so sign up to testify in support of the bill. Just ask your legislator their position on this, encourage them to support it, ask them, be very specific in your asks too, ask them to sign on to the bill as a co-author. That's something that they can do as well. So, it's these sorts of things just take, I've been introducing this every year now for 5 or 6 years, and it can take a while, especially when there's divided government in one chamber that more than likely is not going to support it. So, there's electoral things you can do as well, but I'll just speak to the official side at this point.
I'd like to just snowball, sorry, Dr. Pope. I'd like to just snowball off of what Representative Freiberg said and say that you can also get in touch with somebody from Compassion and Choices. I am still 6 months in or so to my advocacy and storytelling with Compassion and Choices. So I'm still fairly new to all of the dialogue surrounding politics and how to contact legislators and all of those kinds of things. They feel really scary to me. So Compassion and Choices has been great at training us how to do that, and making sure that you don't feel like you're alone in the process as well. So definitely get in touch with someone from Compassion and Choices. You can contact me. I'll put my email in the chat box if you would like more information about that. So yeah.
I'm not a Minnesota resident, so I won't chime in on this part, but I will take my little minute to say to Ms. Nelson, thank you so much for your storytelling, for your advocacy, and I just wish the best for you, and I hope that in the next few months things go well as they can go. So I just want to send out my heart to you.
Thank you so much, Dr. Grube. That means a lot. I'm in a tough place right now, but it's a roller coaster. So you just take it one day at a time, and that's all you can do. I appreciate your well wishes.
And I really want to second that. I mean, you just about took the words out of my mouth there, Dr. Grube. So I appreciate you saying that. And Ms. Nelson, if I could second that, your participation here has been was very courageous and very powerful. And we wish you well. I want to thank everyone. We're a little bit over time at this point. I want to thank all the speakers for their time, for their expertise, for their efforts, and all of the participants for your excellent questions. I am really sorry we did not get to them all, but we will try our best to do some follow-up after the event to try to get to at least some more of them. Because we hate to end an event with so many questions unanswered. And please do consider joining us on February 11th for the second part of the series. You'll see we have some pretty amazing speakers lined up for that event as well. Lots of diverse perspectives at that event as well. So with that, take care, everyone. Hope to see you on the 11th. And thanks for being here today.